with me, and if I get more than 10 minutes, I guess cue the orchestra kind of. Regarding basically access to new patients for Medicare and Medicaid, and I know in our particular office we have 4 physicians, a nurse practitioner, and a physician assistant, and none of us will take any new Medicare or Medicaid. It's not something I really thought in training. You know, when you're in residency in medical school, you're just learning how to take care of people, then you get out and you learn you have to run a business. And for better or for worse, it really boils down to economics. And the reason we are not taking any more of either plan, and that's kind of interesting. I know with Oregon here, you know, we recently covered a lot more children under, you know, Medicaid, but then access to care is a whole other issue. But it's frustrating to have to tell people, and I get often asked, you know, are you taking new patients? And we have to say, well, what is your insurance? And the reasons are, we earn about 40 cents on the dollar taking care of Medicare and Medicaid patients as we do others. And it's difficult to sort of deliver care in a business environment like that. You know, in our office personally, we keep all our patients as long as they want to stay once you're kind of in the door. So we have a fair percentage. In fact, I've been tracking the last several months my patient makeup, and about 30 to 50% of my day is Medicare, Medicaid, or cash pay. And it shows because we all pay ourselves based on production, and I consistently earn less than my partners because my percentage is greater of these populations. And that's just kind of this own sort of personal balance that we reach. But it's a very kind of complex, archaic system. You know, the time that we spend with somebody under the Medicare system in half an hour of consultation about big global health issues will maybe reimburse half of what a 5-minute procedure would, you know, reimburse for a specialist. I know, and I'm not sure about the exact specifics, but the same care delivered here versus in another area of the country, Texas or Miami, will pay for the exact same service 2 to 3 times more. And we used to have a lot more internal medicine physicians in town. We used to have a lot more people accepting Medicare and Medicaid, and there was an exodus. They simply could not keep their doors open above about 40%. I don't know what the exact numbers are, Scott. We have Dr. Gibson here today too. You simply cannot meet overhead. And so it eventually got to the point where the entities that can survive under the payments of Medicare are actually now paying the physicians, i.e. the hospital has salaried physicians just to allow that population to stay in town and use the hospital services. So it's a very, very frustrating situation. It doesn't just impact the people, it impacts businesses in town, the care homes, Osprey Point and Hamptons, and all the other places are stuck because they have rooms to fill, and families who want to bring their relatives into town to place in long care facilities who simply cannot find physicians to care for them. So again, I don't have any answers. I sort of feel like this is kind of a mea culpa to say that it's not because we're not caring, and it's always this very difficult balance between the realities of running a business and, you know, paying 25 employees and paying their health care costs, which go up 10 to 14% each year, and also doing what we're trained to do and what we really want to do, and that's just take care of everybody. So, long answer, difficult question.
Maybe I'll take one of the easy ones here.
There's an easy one?
Yeah. So there's a term I didn't cover. So actually, I do want to say that if I confused you more with the terms, or you didn't understand them and you want me to, or you'd like to go over them some more, I'll stay later and we can talk through those. So a couple of these are actual questions in which there is actually no easy answer. Could you simply expand Medicare as a single payer system? Well, yes. Then you would need to then work through and debate what that means. Do you mean Medicare as the payment system? As you heard from Scott, he's not taking any more Medicare patients, and you heard why. So is that what we want to put in place? Do you mean the benefits that are covered by Medicare? Because they cover a lot, but not everything, and some of the things that they don't cover are surprising. Until recently, they didn't cover prescription drugs. That's very, very recent. So the question is more complex than, can you expand Medicare? You need to think through that three-legged stool that Nick said: cost, access, and quality. Those are the three main issues when you're talking about healthcare reform that you have to think through, and what kind of system do you want to put in place? Someone asked, how much does a person pay for Medicare? And here I'm making the assumption that you're not talking about how much do we as taxpayers pay for Medicare. But actually, the straight Medicare, you don't pay anything for straight Medicare, but many people get supplemental payments or supplemental policies.
They take Medicare out of your.
Yes, they do.
Yeah, that's right. And I don't know how much pays. Does anybody know? How much do they take out?
$94.50 at night.
$90 to $96 a month. Okay. Yeah.
I wanted to go back to that issue, because people are always coming up with sort of, here's an easy solution to the problem, and one of them is using Medicare. And I've heard that before. Let's just keep, right now, you're eligible for Medicare as soon as you hit 65. Well, just next year, make it 64, and next year make it 63, and umpty years down the road, everybody's covered. So I've sort of heard that one, and I didn't realize that what you said, Scott. And the other simple solution is, that I've heard, is for every part of the country, there's a book for a federal employee of what health plan they can buy into, and the Fed will pay a portion of it, and then the employee pays a portion. So just treat everybody like they were a federal employee, that their employer would pay what the federal government would pay, and the employee would pay whatever the employee would pay. And I don't know, they both sound possible to me, but I don't really know.
Those both sound like issues that address cost and maybe access. But the United Methodist Church pays for my health insurance premium this next year close to $15,000 a year. Now, when I started in the ministry 27 years ago, my entire annual compensation was $8,000 a year. So health insurance alone is now just about double what it cost to hire a minister in 1982, including health insurance and pay. So I'm mostly a liberal on this issue, but I'm pretty have a lot of affinity with conservatives who are saying we have to address the cost of health care, not just who's covered. Not just who's covered. We have to find ways, if we're going to continue to have health care that makes any, well, I shouldn't say continue to have health care that makes any sense, because it doesn't make any sense right now. We have to address the delivery issues, not just the coverage issues.
Part of our costs I can address in I've just looked up in various different websites about this particular issue, and I found some interesting facts that kind of blow my mind. Between 2000 and 2007, the insurance companies' profits here in this United States have increased 428%. They are only going to go up. They are not going